same day, because the doctor's talking later and tomorrow. These are all things for you to keep in your mind. So take good note. You all have your little booklets, right? So without further ado, Donna, we'd love for you to come up and share your knowledge. You
presentation, I am going to focus on and patients had to be exposed to a modulatory agent drug, so Revlimid, Pomalyst, monoclonal antibodies such as daratumumab, and a proteasome inhibitor such as Velcade or carfilzomib. So exposure to those drugs with 4 prior lines of therapy. That being said, I think in the near future, we can see this treatment move up to patients who are less treated, so earlier lines of therapy. And I think we're expecting hopefully that FDA approval, hopefully by the end of the year, but that will to be soon for patients with earlier lines of therapy. So that's exciting. The data coming out of these conferences are showing really good results. So patient is deemed eligible, depending on the indication, they will go to a CAR T center. So we know that CAR T is not available everywhere. It's available at institutions that were certified to administer this treatment. And really it's just saying that if someone, I can manage the side effects. So you have to go to a CAR T center. And again, I recommend establishing, if this is a treatment that you're interested in, establishing that relationship with that center before you need it, because it is a process. So we identify a patient, now we have to collect the patient's cells. So that is it parallels to stem cell transplant, where we collect your stem cells. Now we're collecting your T cells, same machine, same process, and it's very parallel. So we're going to collect your T cells. We're going to take those T cells, ship them off to be manufactured. And again, they're genetically engineered to target myeloma cells. And that process typically can take 4 weeks. My experience is a little bit longer. So during that time while those cells are being manufactured, I want to make sure that I have your disease well under control. So you're still going to receive some treatment, and we call that bridging therapy. When the cells are ready to be infused, you're going to come back and you're going to get a different type of chemotherapy. And that's called lymphodepleting chemotherapy. And the purpose of this is to kill off your T cells to make room for the new T cells. So you get 3 days of chemotherapy, and then you'll go into the hospital to get an infusion of your T cells. Typically, this is inpatient, but there are centers that are doing this outpatient. And I think in the future, more and more centers will be doing this as an outpatient. It's really because of the cytokine release. And with the products, the timing is predictable. So that does lead to an opportunity to do this outpatient. But for the most part, this is an inpatient procedure. And you're admitted in the hospital for in my institution, up to 2 weeks. Other institutions are holding patients for a week. And again, it's to manage that cytokine release. And we'll talk about what that means. Then patients are discharged and they're asked to stay close by to the center for about a month, where we can monitor for any other side effects. Usually patients will have low blood counts, that they're coming in a few times a week, and we're managing patients with either growth factor support to boost up their white cells. They may need platelets or red blood cell transfusion. So we're bringing these patients in frequently for the few weeks after discharge to support them. Then after about a month or so, we're sending them back to their referring doctor, and they'll be managed for any long-term complications. So you can see this whole process can be anywhere from most likely 2 months, 3 month process from start to finish. So, like I said, if this is something that is if you're interested in, and again, this will be available for patients who are less treated, make that referral early on. There is an insurance process. And as was mentioned in the earlier session, I'm not really seeing insurance companies deny this treatment, but there is some time that is needed to get that insurance approval. So make that relationship early on before you need treatment. And, as I was saying, patients are usually admitted a week to 2 weeks, very similar to as stem cell transplant. And really what's key about this treatment is you need a caregiver to stay with you, especially right after that hospital discharge. And that's because there could be potential side effects that you might not realize you're having, but your caregiver can note that. So we actually do require that a patient has a caregiver with them throughout the process. Another thing that is, we restrict driving for 2 months. And again, this is because there could be some neurotoxicity. We'll talk about that later. But the good thing about this treatment is it's a one-time infusion and it's done. And then we monitor patients throughout. And patients, what we're seeing, can maintain a remission for over 2 years. I've had patients 6, 8 years post CAR T that are still in remission. So we're really getting deep and very durable responses from this treatment. But there are side effects. So cytokine release syndrome, neurotoxicity, and infection. So the new kids on the block, bispecific antibodies, this kind of mimics CAR T. So instead of taking out your T cells and re-engineering them, I'm giving someone an antibody similar to daratumumab, and it's redirecting your T cell towards the myeloma cell. So you can see here the bispecific antibody looks like a Y. So one hand is grabbing onto the T cell, the other hand is grabbing on the myeloma cell, and it brings the two together. So it mimics CAR T. And the side effects are very, very similar. So these are new drugs, and we've had 3 new drug approvals within 1 year, and I said 2 within a few days of each other. So we're very fortunate. 2 of these antibodies target BCMA. Talquetamab was approved last week, and that targets GPRC5D. So that's a different target with different side effects. The good thing about bispecifics is they're off the shelf. There's no manufacturing time. So if a patient needs therapy, they can start therapy right away. So there's no bridging involved, but because of this risk for cytokine release, there is ways that we need to mitigate. So patients often will have to be admitted to the hospital for up to 10 to 12 days, depending on how they react to the treatment. And we give step-up dosing. So a little dose for the first dose, a little bit higher for the second, then we can give a full dose. And that process can, like I said, take average is 10 days, but it really will depend on the product and the dose. And then the patients, after that step-up dose, will get it as an outpatient, either on a weekly schedule or a bi-weekly schedule. And again, it's going to be drug dependent. The 3 agents that are approved, so talquetamab, teclistamab, and elrantinib, they're all sub-Q injections. So it's an injection right under the skin in your belly. So very easy to give. And again, once you're through that step-up dosing, it's an outpatient treatment. We tend to keep patients right now on therapy until disease progression, but there is going to be, I think, some room for modification once more studies come out where we need less frequent dosing. So I want to get into the side effects of these novel therapies. So I keep mentioning cytokine release. So cytokine release, when you're redirecting your immune system, it releases these cytokines. So cytokines are little immune substances that go into the bloodstream and can cause havoc. And it can affect different parts of the body. So the hallmark sign of cytokine release is fever. All patients will present with a fever, and it can progress to low blood pressure or difficulty breathing. These treatments have to be given in, again, a certified treatment center, but these should be, in theory, more widely available because they're off the shelf. What a patient typically will describe of what CRS feels like, it's usually a fever, but it kind of feels like after the flu shot, the next day you're kind of feeling low-grade fever, achiness. And that's what we're really seeing with the bispecifics. With CAR T, it could be a little bit higher fever, but bispecifics, we're seeing lower grades of CRS. And we have an antidote for this. So we usually will manage patients with Tylenol. There's a drug called tocilizumab, which is the antidote. It puts the brakes on the cytokines. And usually this is very self-limiting. and it will resolve. So that's why we're keeping patients in the hospital, because there's a potential for multiple side effects and self-limiting and reversible. So neurotoxicity is rare, but it can happen with these drugs. And this is where I think the caregiver becomes very crucial. And this can present as a headache, to confusion, to being very tired, hard to wake. And this can happen simultaneously with CRS, or most likely it will happen after, so later on. And this can actually happen later on after a patient is discharged. That's why caregivers are very important to this process. And, I've had patients report confusion, and again, it's usually the caregiver that will report in. I'll have a patient tell me the date where they are, but they can't tell me who the president is or what state they're in. So it can be confusion. We can also notice some changes in handwriting. There's some maybe fine tremors. When you're in the hospital receiving these drugs, you're getting a neuro exam every day. And then when you go home, that caregiver becomes a very important part of your healthcare team, and they're going to note any type of confusion. This again is self-limiting, and we tend to manage neurotoxicity with steroids. So this is really where I want to stress with these new drugs, especially that target BCMA. So that's going to be both your CAR-Ts and teclistamab and elrantinib. They target BCMA, and they put patients at very high risk for infection. So in the studies, over 60% of patients had some type of infection, with a third of patients having severe infections. So the definition of a severe infection is either requiring a hospitalization or IV antibiotics. So this puts you at high risk. So this is something you need to be very mindful if you are receiving these drugs. And you're also at high risk for COVID complications. So right now, I think in New York City, in the southern states, we're experiencing a little bit of a uptick, and I think that's just going to keep going up with the fall and this winter months. At our institution, we're checking antibody levels monthly. And even if you've had the COVID vaccines, it still puts patients at higher risk. We're seeing that patients aren't really mounting a response to the vaccines, and patients who do test positive for COVID, they're testing positive for an extended amount of time, over 3 months. We swab them and they're still testing positive. They're carrying that virus still in their nasal cavity. So it's something we want to be mindful. That's not to say that they're contagious, but they're just holding on to that virus. So as soon as you start having symptoms, test yourself. There's a drug called Paxlovid that we're prescribing patients at the first sign of any symptoms. So make sure you're reporting that out and testing yourself if you start having symptoms, because I think the numbers are just going to go up as the year continues. We were lucky over the spring and summer to have a nice lull in the COVID, but I had 5 patients last week that tested positive for COVID. So another thing about infections. So again, infections, it could be viral, bacterial. Patients are at very high risk. So practice good hygiene. Just know your risk factors. If you're in a crowded room, exception of this room, know your risk. I know we're all like, yes, we are in a crowded room, but if I'm on an airplane and a confined, I'm going to wear a mask. Just know what's going around you. If you're in an area that is starting to spike, I say good prevention. Get your boosters. I know vaccines have caused some controversy over in this country, but they really do provide some protection. Others may not amount a response. So have that conversation with your provider to see if a COVID booster is right for you. The new boosters should be coming out later this fall. And again, high quality masks in high risk situations. Other things that as a healthcare provider, I'm going to be monitoring your white counts. If you need some support, if your white counts are low, I can give you growth factor support. Immunizations, and we'll talk about that on the next slide. And then medications. If I see that you're high risk, I might put you on prophylaxis. So the different types of prophylaxis. So shingles, we're giving patients are at higher risk for shingles. The different medications we give, such as Velcade or Carfilzomib, they can put you at high risk for shingles. So everyone in my practice is on a Cyclovir or Veltrex to give them that protection. PJP is a type of pneumonia. This is an opportunistic infection. And we're seeing this more and more with patients, again, with the BCMA-directed therapy, so CAR-T bispecifics. If I think you're at high risk, I might add in an antibiotic prophylaxis like Bactrim to give you that protection. RSV. So this became an issue last season. More patients were hospitalized with RSV and COVID. Later this season, probably October, we should have vaccines to prevent severe infection. So this is a new vaccine that was recently FDA approved for patients over 60. I recommend, again, having that conversation to see if this vaccine is right for you. There were some questions about IVIG with hypogammaglobulinemia. So patients with low IgG levels, and we see patients who are on those bispecific BCMA-directed therapies or CAR-T therapies, their healthy IgG levels drop, and they drop quickly, and that puts them at high risk for infection. So anyone who's on a BCMA-directed therapy, in my practice, will get monthly IVIG. And then patients who are on CAR-T therapy, I start IVIG before they get their cells, and they stay on that until their healthy IgG recovers. So IVIG is really important for infection prevention. So there's other things we can do to support you through your treatment. A lot of the immunomodulatory drugs, so Revlimid, Pomalyst, they can cause clots. So if you're on those type of drugs, you have to make sure that you're at least on a baby aspirin to prevent clot formation. If you find yourself in a higher risk situation where you're taking a long flight or a long car drive, let us know. You might need something stronger than a baby aspirin. I recommend compression socks for if you're going to be seated for long periods of time. Bone health, we'll get into a little bit more about pain, but we talked about with the Q&A session with Dr. Dury, bone strengtheners. So a lot of my patients will initially start off on bone strengtheners. And again, that's to fortify the bones. Vitamin D, especially in New York City, everyone is D deficient. I think we live indoors too much. So almost all my patients are on vitamin D. I check vitamin D levels every 3 to 6 months and make sure that they're in a good level. Calcium, also another supplement that we use. Just check with your healthcare team. If you're borderline high of calcium, I don't want to add more calcium so that shoots up. So just check with your team. And we'll talk about pain management later on. Kidney health. Kidneys, so about 18 to 20% of patients when they're initially diagnosed with myeloma have some degree of insufficiency with their kidneys. So kidney health, and we know myeloma can affect the kidneys. So we need to make sure that your kidneys are healthy. We try to avoid any drugs that can harm the kidneys. So if you're starting any new prescription, run it by your myeloma team to make sure that there's no harmful effects on the kidneys. And you must maintain adequate hydration. I'm guilty. I think I've only had a glass of water all day. But really you should maintain 2 liters of fluids a day to have really good, healthy kidneys. We spent a lot of time talking about infection prevention. We'll talk about peripheral neuropathy and other GI issues. So symptoms of myeloma. The disease itself can cause significant side effects. I think everyone in this room will report some degree of fatigue, constipation or diarrhea, pain from lytic lesions or bone lesions, neuropathy, but there's also a psychological toll. So patients will report depression, anxiety, mental fogginess. And then we often don't think of this as a side effect or a toxicity, but financial burden. Multiple myeloma is the most, I won't say the, but one of the most expensive diseases to manage. Yes. Steroids. So I think steroids, there are so many side effects associated with steroids, and they are the backbone of many of the treatments we give. It really affects every body system, but the good effect of steroids is that it synergizes with a lot of the treatments we give, so it enhances the effect. So they're so important in our combination therapies, but they cause so many side effects. Irritability, mood swings, insomnia, cataracts, blurred vision. So patients who are on steroids, yearly eye exams are key. Many of my patients do have cataracts, sorry. And then we talk about infection. Steroids can put you at higher risk for infection, weight gain, increased appetite, and it can also cause muscle weakness. So these are all things you need to keep in mind when and I think this is actually, a lot of my patients report side effects from the steroids. They are difficult to manage, but we can take it with food to help decrease any of this stomach upset. This timing of when you take your dexamethasone or your steroid, some patients will take it first thing in the morning with breakfast, so it minimizes the insomnia, but other patients find it more helpful to take it right before they go to bed, and it will wake them up in the morning. So whatever works for you, what works for one patient doesn't necessarily translate for everybody. GI symptoms. So the treatments we give definitely cause either constipation or diarrhea, and how we manage diarrhea, and especially patients who've been on Revlimid maintenance, diarrhea often comes up as a side effect that's bothersome. So, we definitely have anti-diarrheal medications. We can alter someone's diet. Constipation, also a lot of the treatments we give can cause either constipation or diarrhea, but also pain medication that we give to manage patients' pain, that can cause some constipation. So again, with dietary changes, but we also have stool softeners and laxatives that we can give patients to help manage either or constipation or diarrhea, pain. So bone disease, about 80 to 90% of patients with myeloma do have some degree of bone disease, whether that's a lytic lesion or osteopenia, osteoporosis, and that can cause significant pain. So we give the bone strengtheners such as Zometa or Exgiva to fortify the bone to decrease any incidence of fractures. So that's one thing we can do to help with that. But it's important to identify the source of pain. If it's one location, we might be able to do some radiation therapy and zap out the cells in that area, so to relieve patients of pain. Also, there are surgical interventions. Many times patients will present with a vertebrae that's collapsed, and we can insert some cement to relieve that pressure off the back. Many times we manage pain through medications. So it's important, no one needs to be a martyr. We can help manage your pain. And look, it was scrambler therapy was right on that slide. So that is an intervention for neuropathy. But neuropathy, I will say, is for me one of the most difficult things to manage. There is no silver bullet that I can give a patient that will take away their neuropathy. I'll say it again, what works for one patient might not work for the other. So it's been very challenging to manage this. Neuropathy can present as pins and needles sensation, numbness, to the point where it's very painful. Patients are walking down the hallway very staggered, and no one should ever let the neuropathy get to the point where you're not walking well. Report those symptoms as soon as you start feeling something. The best way to mitigate that is changing around a patient's treatment. So if they're on Velcade, we used to give Velcade as an IV push. We changed that to an injection in the belly because we saw that 50% of patients were getting neuropathy with the IV versus 30% of patients as an injection. So we changed how we gave the Velcade. We can decrease the schedule. We can decrease the dose, and we can change the whole regimen if it's becoming affecting your quality of life. We talked about supplements. So I like to try to rule out any other cause of neuropathy. I had a patient who was actually vitamin B deficient. Once we supplemented vitamin B, her neuropathy went away. Or if someone has diabetes and it's not well controlled, maybe if we get that better controlled, it can relieve some of the neuropathy. There are other drugs such as gabapentin, Lyrica that can help some patients, but it doesn't help all. And you heard today in the room that some things help other patients. And yes, I actually did have a patient that would put Irish Spring in their sheets and said that worked, but that's not going to work for everyone. And I don't even think they make Irish Spring anymore. I haven't seen it. So it's tough. And I just really have to work with patients to see what works for them. But let us know, and I'm happy to work with any patient to help with their neuropathy. So fatigue. So like I said, everybody has fatigue. The disease can cause fatigue with low red cell count. Patients are anemic. The treatments we give make patients anemic or have that side effect of fatigue. So there is some degree of fatigue with everything we do. Anxiety, over a third of patients, depression, a quarter of patients, but I actually think these numbers are well underreported. Patients don't often report these symptoms, but we have a lot of resources for patients. So you need to tell us if you're experiencing any of these. There are medications that can help patients who are severely depressed. We have support groups and other support mechanisms. We can get patients through these times. So let us know. Rest and relaxation, especially with steroids, it sometimes is hard to do. Patients aren't sleeping well. And if you're not sleeping well, the rest of your day is not going to go well. If insomnia is an issue for you, again, let your team know. There are things we can do for you medication-wise, but also creating a nice sleep hygiene. Don't bring your iPad to bed. Put your phone in the other room, because I'm guilty myself. I go to bed at 10, but then it's 12 o'clock before I really shut my eyes because you're always on your phone. Put all the distractions in another room, and your bed is just for sleep. I talked about financial burden, and I will say it again. It is one of the most expensive diseases to treat. CAR-T therapy, just the infusion, just the cells is $500,000, and that's not all the supportive care I need to give patients. So this is a very costly disease. Patients find themselves in donut holes, co-payments, medical supplies, prescription costs. There's so many things that we're paying for. And then we can't forget loss of income. So taking time off from work to go to doctor's appointments to get treatments, even as a caregiver, taking time away from work, it really is a burden. There are many programs available. You have them here and in your books. The LLS has grants for patients for prescriptions. If you find yourself with high copays, there are many resources for patients. Utilize them. Sometimes they go underutilized. So Cover My Meds, needymeds.com, very good resources for patients. And most practices have a social worker as part of their practice. That social worker is a great resource and probably knows more resources than I know. So make sure you make that connection, even as an introduction, because there might be times where you fall into that insurance gap. So I want to stress like shared decision making. You are central, as you can see on this image, you're a central part of your care team. Make sure you're part of the decision making. Know all your treatment options. And if you want to get a second opinion, go to that myeloma expert if you need to. Don't be afraid to hurt anyone's feeling. Get that second opinion. Be the central part of your care team. Let us know your goals, your milestones, what you want to accomplish, and we will make that treatment plan fit your needs. It's not me dictating what you're going to do. You need to be part of that decision. And the IMF has all the resources you need on information on the different drugs. There's conferences or seminars like this, online resources. The hotline is very useful. Someone's always there. You call them and they can lead you in the right direction. So knowledge is power. Someone prescribes you a treatment regimen, get that information and then come back to me with all your questions. So healthy living, I think, is important. We talked about kidney health. So you want to make sure that everything, you're the best you can be, because then you're going to tolerate treatments better. So kidney health is important, adequate hydration. Make sure, I know myeloma is always front and center, but don't forget everything else. Don't forget your annual exams, your other screenings, colon cancer, breast cancer. There are other things that patients have parallel to myeloma, and they often get forgotten because everyone's focused on their myeloma. Make sure you still go to your primary care, get all your yearly screenings, make sure you're up to date on your vaccinations, flu, seasonal flu, pneumonia, again, infection prevention. This is where patients get into trouble with infections. Bone health, we talked about the supplements, the bone strengthening agents, and then activity actually can help your bones. Make sure you're active. Nutrition, I never say deprive yourself of anything. Patients will come to me telling me they're not taking any sugar. I don't think you should deprive yourself. Everything in moderation. I could never deprive myself of something sweet. So, a good healthy diet within moderation. And then manage stress levels. If you're having a difficult time, reach out to us. We can help you through a lot of these difficult situations. And then other healthy things, yoga, Pilates, anything low impact, I think is good. Some of the best things I think you can do for fatigue is actually get up and go for a walk. The more sedentary you are, the more you're going to increase your fatigue. So something low impact, going out for a walk, can actually help your fatigue. Don't force it, do what you can. No one's saying you need to run a marathon, but just maintain your activity. So with that was my last slide. So I'm happy to take any questions. Thank you.
Number 5. Please. Thank you. So as much as we know how important our doctors are, we all know the importance of our nurses. We talk to our nurses in different ways. We ask them different questions. So hearing from Donna today, now it's your opportunity to ask those questions about the things that you talk about in your support groups and you really want to ask. These are your people, right? So when you're on Revlimid and you need to talk about diarrhea or constipation or any of these things, now's the time to do it. Don't be bashful. Everybody here has had that issue, right? Maybe not all the caregivers, sometimes. So Q&A time. We've got Sapna starting us off.
You mentioned that one strategy for DEX might be to take it in the evening rather than the morning. Does it matter if you take it the morning of your other shots or the evening before?
It's a good question. So the majority of my patients will actually take it first thing in the morning with breakfast. But for the handful of patients that find it better to take it at night, we'll take it either or. So I just say later that night is fine for patients. If it's day one of their treatment, take it that night.
Jonathan, do you have a question over there?
Thank you. So when you were talking about neuropathy and pain, there's a reference to scrambler therapy, and I Googled it while you were talking, and it's fascinating. Could you talk a little about that?
I don't have experience with that. Our institution, we don't have that available to us, but someone in the audience did.
Okay.
Ups, and you already had a stem cell transplant, would you and then have a second stem cell transplant, or would you have a bispecific antibody?
Your disease is gonna dictate how I manage the next step. A second transplant, we don't do as much as we did when I first started my career. We didn't have the plethora of treatment options when I first entered my nursing career as we do today. But a second transplant is still a viable option. We tend to collect stem cells enough for at least 2 transplants. And if you got 10 years out of your first transplant, in theory, we say you got about half of that with your second transplant. So you could get additional 5 years. But the second transplant, at least in my institution in New York City, we haven't been doing those second transplants since the advent of bispecifics, CAR Ts, and these other therapies.
Oh, for okay.
Hi there, wonderful presentation.
Thank you.
I have a question about the drug Pamelar. I've been on it for about 10 years and it's definitely controlled my neuropathy. I am now up to 50 milligrams. I've asked several of my support group members to ask their doctor about it. And they came back with telling me that their doctor didn't recommend it because they had heart issues. Could you tell me the reasons why, or is it that the only reason?
You know, it's actually been a few years since I've actually prescribed it. It does work for some patients, but I don't really use it as much as I did a few years ago. It could be heart issues. You know, I think in my practice, we use a lot of gabapentin, a lot of Lyrica. We find that that has helped patients more, but like I keep saying this over and over again, especially with neuropathy, what works for you, it's not translatable across all patients. So it's hard. So it's more trial and error with neuropathy. If that works for you, then, you know, it's on my list of neuropathy drugs that I try with patients. It's not my first go-to, but if you're tolerating it well, you know, that's really what I can speak to, that it's working for you.
I have a question regarding the Revlimid. You talk about diarrhea and constipation, but does Revlimid cause acid reflux or acid issues? Because I have 2 endoscopies done and they couldn't find anything. So I'm on famotidine every night to kind of keep the acid, you know, stable per se, and to avoid all the triggers, but I still have issues with it.
So it could be, the majority of the time is it's usually the steroid that's causing the reflux. You're not on steroids.
No.
And they've done the,
2 endoscopies.
it could be the Revlimid. Like I said, 9 out of 10 times it's the steroid that's causing a lot of the reflux that I see in my practice, but it could be the Rev.
Okay, thank you.
Oh yeah, what you're having for dinner, avoid those spicy, high-fat meals.
Yeah, a lot of people start on Dex at 20 and 40 milligrams. Do you talk about reducing the Dex?
Yeah, so For my patients over 70, I will already reduce the dex to 20. My younger patients will start at 40. We'll see how that goes. And like you said, there's so many side effects associated with dexamethasone. I can reduce the dose, but sometimes I find that patients, if I change the type of steroid I'm giving, so prednisone, if I give it Monday, Wednesday, Friday, patients might tolerate that better than a big dose of dexamethasone once a week. So I try to work and see maybe dex is not the best steroid for a particular patient. So I can change things around and work with different steroids.
Hi, you mentioned that quite a few patients also have kidney issues. And so to manage that, would you recommend steroidal or non-steroidal MRA?
Take the Advil out of take all those drugs out of your medicine cabinet. Know what your renal function is, what your baseline is. Every time a patient is coming in, I'm drawing labs anyway, so I'm monitoring them. But anything like IV contrast for a scan, those can all harm the kidney. So if someone's baseline renal function is already a little compromised, I have to make sure I give patients extra hydration. But any medications that can harm the kidney, take it right out of and have that conversation. Maybe there's a risk benefit to the medication that the patients need to stay on, but usually I get rid of all the non-steroidal medications like your ibuprofen, Aleve. Those medications are not good for the kidney. It's really just Tylenol. And if you need something stronger, talk to me. I can prescribe you something that's a little safer for the kidneys.
Come on, folks. I know there's lots of questions for nurses. Hands up. Who's got, all right. Sherry over here in the middle. You're next. Jonathan will go there.
Who would be a candidate for the CAR T-cell therapy?
So right now, you need to have had 4 prior lines of treatment. So someone who's relapsed or refractory, 4 lines of treatment, were exposed to either Revlimid, Pomalyst, daratumumab, Velcade, carfilzomib. You had to be exposed to each class of drug, 4 prior lines of therapy. We'll say that I'm anticipating another FDA approval that will push it up in earlier lines. And there are studies right now looking at it even earlier lines as newly diagnosed or post-transplant in the maintenance setting. So there are many ongoing clinical trials, but I think we're going to start seeing the CAR T therapy go earlier and earlier. So if you're a candidate now for commercial CAR T, you need to have 4 prior lines, but always go for that referral because at our institution, we have the clinical trials looking at CAR T in earlier lines. So there might be other options for you if CAR T is of interest to you.
Donna, could I ask a follow-up question on that? Because maybe some of the newer folks talk about what a line of therapy is. So it's not just.
I know. So a line of therapy, it can be a combination of drugs. So your first line of therapy is going to be when you're newly diagnosed. If you get a few cycles of Velcade, Revlimid, and Dex, you went to transplant, then you had maintenance therapy with just Revlimid. That's one line of therapy. Your disease came back. We changed the treatment to something else. Another combination of drugs, that's your second line of treatment. Each time we change the regimen, that's a different line of treatment. So just keep in mind when you're newly diagnosed, there might be that chunk of time is considered one line of therapy, but with each relapse is a different line of therapy. So each combination of drugs that you get is a different line of therapy.
Hi, Donna. Thanks for answering our questions. This one, I don't know if this is in your wheelhouse, but I noticed in talking to patients that there's, I know we're all different, but when we're on the same therapy, I'm seeing differences in, like, let's say Darzalex. I started Darzalex Revlimid 3 years ago, had to drop the Revlimid. It was just kept beating up my blood count. But when I talk to other people on Darzalex, they're like, oh yeah, all the pre-meds that I had to take, but they're not all the same. Like, I was on, well, the Dex obviously, but also the Tylenol and the Benadryl and the asthma drug,
Singular.
Singulair. Yeah. But I talked to other patients in different hospitals, different places. They're like, oh no, I didn't have to do Singulair, or I'm still 3 years later doing Benadryl and Tylenol and whatever. Why isn't there, and again, this may not be a question for you, but I would think that when whoever, Janssen, comes out with Darzalex, they say, okay, here's the pre-meds. This is what was in the clinical trial. Everybody's going to take this for the first 6 months you're on the drug. And most of those are to prevent allergic reaction. So if you've been on it for 6 months and you've never had an allergic reaction, then is it safe to go off of them? Why is it also sort of discretionary? And why do some patients are all on the same pre-meds and others aren't? That just always confuses me when we talk among patients and compare stories that we're all doing a slightly different type of thing with the same drug.
Institutional guidelines. So my institution is going to be different from your institution. We gave so much daratumumab since the beginning. So we actually added in Singulair very early on and saw that patients had less reactions. But we are also discontinuing the pre-meds once we establish the patient is tolerating the drug well. That's our comfort level. I can't say if I'm going out into a community practice in Long Island, New York, they're going to have the same comfort level and the same guidelines and practices. So, and for Janssen to say, come up with a established pre-meds, they make the recommendation what you need to do to prevent an infusion reaction or a reaction to the medication. It doesn't really say how long you must stay on these medications. It's really physician discretion or institutional discretion. So it's going to vary between institution and comfort level. We see 5,000 myeloma patients a year. So we have a different comfort level than a community practice that sees 5 myeloma patients a year. So there's going to be variations between different practices, and it's all about that practice's comfort level.
I think that the doctors, let's say someone who's not at a research center like where you are, like I'm at in Boise, Idaho, we don't have a research center. And the doctors there, their information is coming from Janssen or coming from, I feel like there's so many patients that are taking things extended periods of time that they don't maybe need to take anymore, like in the case of Benadryl. Every time you go to get your Darzalex, when you've been on it for 3 years, because nobody asked as patients, I asked, I'm like, God, the Benadryl is killing me to drive home. Can I please stop taking it? And my doctor said, yeah, you've been doing this for 6 months, no reaction. It's okay to drop your pre-meds. Every time I go to the clinic, my clinic goes, so did you take your pre-meds? And I just say to them, I don't have to take the pre-meds anymore. And they're like, okay, fine. But I feel like either the patients aren't asking the question, but also that no one's educating the doctors and then trickle down also the nurses or coming up with guidelines. Like you guys have your guidelines, but a lot of the smaller clinics, non-research centers, I don't think anybody talks about guidelines for how long we should do this. I feel like that needs to come from somewhere, whether it's Janssen or IMWG or NCCN, somebody. But I just feel like as patients, too many times we go with the flow. Nobody asks a question of their doctor and they just keep taking it, just like the Dex. But anyways, I guess I get frustrated that there's not a better guideline or to tell people in smaller centers. You guys obviously come up with guidelines for your patients because you see that many patients every year.
Sherry, I think this is one of those things where no question is a stupid question. Everybody in here should be able to ask whatever, but if you're having, like if Benadryl is making you feel crazy, you need to talk to your doctor or your nurse about that. And even in our support groups, we talk about this, how important it is to just ask the question. If you don't ask, they're not going to know that you have the question, right? So one, ask the question, and two, and again, I'm not a healthcare professional. I'm a 23-year caregiver. But the other thing is the combination of having your wonderful local heme onc, who's the one that if you end up in the ER and when he's carrying out all those instructions, right? You have that person to ask the questions to, but then you also have your myeloma experts, the ones that are dealing with myeloma all the time. And they maybe know better. Yeah, you've not had side effects. Maybe you don't need X drug pre-treatment for X, whatever it is you're doing. But that's why you use, if you can, your myeloma expert, ask them the question. And then when you talk to your local nice hemonc, say, hey, I just talked to, Dr. Expert, and they're saying that it's okay. And then your local hemonc, usually ours at home, has said to us, I'm learning through you from the experts because they don't have time to go to these big ASH and big conference meetings. So, I mean, Donna, what are your thoughts
So,
on that?
2 points. Never just because it was told to you, take it verbatim, always question. And that's part of what I'm trying to say. Be empowered. You're part of the team. Be empowered to question everything. Second thing, like my role as a nurse practitioner, and I sit on the nurse leadership board, we try to disseminate information to our nursing colleagues. Disseminating that information on how to properly manage patients, we're doing that. It's a task. But again, case in point, you're really stressing the point is you need to be empowered to question everything. And that's fine. I'm not going to be offended if you ask me, why am I taking this steroid? Why am I taking Benadryl? And we can work together to make sure that you have the best quality of life. And if Benadryl was not, and again, going to that myeloma expert, I will stress that, making those recommendations and bringing it back to your local provider. But we are trying to disseminate information to my colleagues.
And Donna, did you talk about Myeloma University and how you are educating out there through 2 other nurses?
Yes, we do have a video series, Myeloma University, which has we talk about monoclonal antibodies. We talk about CAR T therapies, the different classes of drugs. It's, I believe the link is on the IMF webpage, right? And it was actually geared towards nurses, but patients are actually finding it very helpful as well. And they're little, 5 to 10 minute video clips explaining the different treatment options for patients. And again, it was really geared towards nurses, but patients are getting a lot out of it.
Thank you so much, Donna. Thanks everyone for your
Thank
questions.
you.